Assalamualaikum. This is Dr. Amna, and today's presentation is about hyperthyroidism management in pregnancy. So, these are as with any other uh, medical condition, as I have mentioned, that there's a common routine when patient comes in preconception clinic. We tell the patient we want to see the medications that no patient is not taking any medication which is teratogenic, and she has good compliance, and her recent investigation regarding her conditions are okay. We will explain the patient the effect of condition on pregnancy and effect of pregnancy on her condition, and also we will advise her folic acid if she needs high dose folic acid, then we will advise that, and if routine, then she will have 400 microgram. And same, this is the same scenario for every medical condition. So hyperthyroidism has an incidence of 1 in 500 pregnancies. 95% of these cases are due to autoimmune thyrotoxicosis. So Graves' disease is a major reason of the hyperthyroidism. Other causes include a toxic nodule or toxic nodular goiter. Thyroid function test in hyperthyroidism showed decreased TSH and elevated free T4 and T3 levels. So in normal pregnancy, what happens that thyroid binding globulins are increased in the body. So overall total T3, T4 levels are increased, but the total T3 or T4 may be increased, but this does not affect on the thyroid functioning of the thyroid status of the patient, because we can assess the functioning of the thyroid according to symptoms can develop according to free T4 and T3 level, not the total T4 and T3 levels. So this is the normal cycle of the thyroid. Like we can see that the hypothalamus release thyroid releasing hormone which act on a pituitary gland on, and pituitary gland then responds to TRH produce TSH, thyroid stimulating hormone, and which act on thyroid gland and produce T3 or T4. Then T3, T4 are released in the peripheral circulation, and then there goes the negative feedback on the pituitary whenever there is T3, T4 levels are raised. So this is the normal cycle. So in this condition, where hyperthyroidism, where major causes for hyperthyroidism in Graves' disease. So this is an autoimmune disease, Graves, in which there are thyroid receptor antibodies. These are mainly thyroid stimulating immunoglobulins, which act on thyroid, and thyroid become hyperactive. So when T3, T4 level even increased in the peripheral circulation, then goes the negative feedback on the pituitary, and TSH is released. TSH levels reduced because there's a negative feedback. TSH levels are reduced, but now gland is not under the control of TSH. Gland is acting according to thyroid receptor antibodies. So that's why it's continuously stimulating. It does not make any difference that there is an increased level of T3 or T4 in the blood. So these are the causes of hyperthyroidism in general. Autoimmune, which are major, is the Graves' disease, toxic nodular goiter, toxic adenoma, subacute thyroiditis, iodine therapy, and drugs, amiodarone and lithium. Iodine therapy is given normally to treat hypothyroidism, but when we give the very extra dose of iodine, it can in turn lead to hyperthyroidism as well. So aim of pregnancy care with thyroid disease is to ensure all of the following for women with thyroid disease in pregnancy: early identification, optimization of treatment, appropriate monitoring of thyroid function, appropriate monitoring of maternal and fetal well-being, provision of evidence-based information to women and their partners. So there is another phenomena in the first trimester in normal patient who do not have this condition, hyperthyroidism, in normal condition. But when they become pregnant and they go through the increased beta ICG is produced, it can hyperemesis gravidarum can be in normal pregnancies as well, but it's mostly seen in the pregnancy where increased beta ICG level is there because of twin pregnancy or molar pregnancy. So there's increased beta ICG production. So beta ICG shares alpha subunit with the thyroid stimulating hormone. These two have different beta subunits, but same alpha subunit. So whenever there is a beta HCG is produced, these alpha subunit also act on thyroid like thyroid stimulating hormone. So in response to this beta HCG, thyroid hormone releases T3, T4 level, which is not in control of pituitary, because pituitary, when there will be negative feedback goes to the pituitary and TSH is not released. But thyroid is not acting under the influence of TSH. Thyroid is acting under the influence of beta HCG. So in the first trimester, when patient is having hyperemesis gravidarum, she can also show the symptoms of hyperthyroidism. So it is very sensitive point at this point, because there can be confusion whether this is undiagnosed case of hyperthyroidism or she is the case of hyperemesis gravidarum with the increased thyroid functions. So how can we differentiate it, and how can we manage this condition? We will discuss it now. Transient biochemical hyperthyroidism. In elevated T4 and low TSH may occur in up to 11% of women in early pregnancy. Common in those with hyperemesis gravidarum due to TSH receptor stimulation by high levels of beta HCG. This is because TSH and beta HCG share same alpha subunit. This transient hyperthyroidism has not been associated with adverse pregnancy outcome. So how can we differentiate between two? We will take careful history. Whether patient is because if patient does not, if patient has history of thyroid hyperthyroidism, then we can say that the symptom can be because of hyperthyroidism. But if she does not have, there are two chances: whether this is these symptoms are because of thyroid hyperemesis gravidarum, or patient is having undiagnosed condition. So we will ask her symptom prior to the pregnancy, whether she was having a weight loss and heat intolerance, and also tremors. We will ask from the history, and also we can check during the first trimester that tachycardia, which is seen in hypergrammasis gravidarum. When we give the fluid, the tachycardia settles. In contrast, if tachycardia is due to hyperthyroidism, it does not settle with the IV hydration therapy. Usually resolved by 18 weeks of pregnancy. Obviously, hyperthyroidism will not resolve by 18 weeks of pregnancy. Treatment with antithyroid medication is therefore not recommended. So a detailed history should be taken for any other symptoms of hyperthyroidism, and TFTs should be interpreted with caution, because in this T3, T4 will be increased and TSH will be low. So we should not resemble the test of hyperthyroidism, but we will take a detailed history, and also we will check how will it resolve, and we will also see the response of tachycardia after hydration. Transient hyperthyroidism associated with hyperemesis gravidarum, we usually have no history of thyroid disease and no goiter. If there is any doubt as to whether abnormal TFTs may be related to hyperemesis gravidarum or Graves' disease, check thyroid receptor antibodies, which should be negative. Because in Graves' disease, as I have mentioned, there are thyroid receptor antibodies, which are thyroid stimulating immunoglobulins. These will be negative in Graves' disease. So now after that, we will do the risk of poorly controlled hyperthyroidism. These counseling should be done in the preconception clinic. We will explain all these points to the mother, that her compliance to the treatment is very important, and she should not discontinue the medications on her own. And how will it affect the poorly controlled hyperthyroidism in pregnancy? Weight loss, palpitation, pregnancy-induced hypertension, increased risk of preeclampsia, placental abruption, thyroid storm, crisis, rare but serious 25% mortality due to supraventricular tachycardia in thyroid storm, congestive cardiac failure. In the fetus, miscarriage, transplacental transfer of maternal antibodies causing fetal thyrotoxicosis, tachycardia, growth restriction, oligohydramnios, excessive fetal movement, goiter, and high output cardiac failure. This is very important point to remember, and we will, the major management of hyperthyroidism along with the adjustment of medication to the mother, there is this risk factor in the baby which we need to monitor carefully, because these antibodies can cross the placenta. Antithyroid medication can also cross the placenta. So it's very important that we should be we should keep in mind that these antibodies, which are stimulating maternal thyroid, it's also stimulating baby's thyroid. So baby is also hyperthyroid. So baby is also having same things like weight loss and tachycardia, which will appear in tachycardia, growth restriction, oligohydramnios, excessive fetal movement, goiter, high output cardiac failure. So we will do the serial scanning to monitor all these things. And if we see this is affecting the baby, then we may need to increase the dose of anti-thyroid medications because they also cross the placenta, and it will act on baby's thyroid so that baby has less T3, T4 levels. Intrauterine growth restriction, prematurity, hydrops fatalis due to higher output cardiac failure, intrauterine death, and seizure disorder, craniosynostosis, and associated intellectual impairment. Craniosynostosis mean is bossing of the frontal bones. So treatment of hyperthyroidism, there are two options. Two antithyroid drugs are used in the pregnancy, propylthiouracil and carbimazole. So we will discuss this is a discussion on these medication because normally carbimazole is used to control the non-pregnant patient generally. It's effective in large number of patients. But it has during the pregnancy, why should we do? Whether we will stay on carbimazole or propylthiouracil. So we can discuss both medication. Risk of anomaly 2 to 3% with propylthiouracil, usually minor, face and neck cyst. But in carbimazole, 2 to 3%, including more serious anomalies like aplesia cutis, esophageal atresia, facial abnormalities, and developmental delays. So normal generally dose is 100 to 600 milligram per day, required in multiple doses. So aim in this antithyroid medication dose is that we will keep the dose lowest possible we can. And also the dose of carbimazole is 10 to 40 milligram per day in a single dose. And risk of hepatotoxicity is rare but can occur in propylthiouracil. So we must check the LFTs every 3 to 4 weeks if we start propylthiouracil. And carbimazole is not associated with hepatotoxicity. Both cross the placenta. So both has equal risk of agranulocytosis. So what will we do? There are two things. One point is that mostly clinicians use that they start if patient is on carbimazole, they can start propylthiouracil when the patient become pregnant, and they will continue it till 16 weeks, so that there is no major risk of major anomalies should not be there with propylthiouracil. And after 16 weeks, they shift the patient on the carbimazole again. So there is another discussion about this because this decision is very sensitive, and this should be in collaboration with the gynecologist and endocrinologist and the patient. Because this is also another view that maybe switching medication does not give as benefit because as it takes a long time for the patient to keep her thyroid hormone level in normal range, desired range. And this is done with the long monitoring with the specific medication and specific dose. So when we are achieved to obtain euthyroid state before pregnancy, and in the pregnancy we immediately change from carbimazole to propylthiouracil, they say it caused more damage to the mother as compared to the benefit of the avoiding of serious anomalies. So this discussion we will discuss with the patient and physicians and gynecologists. Then this is MDT decision. Treatment of hyperthyroidism is either propylthiouracil or carbimazole may be used in pregnancy. Both medication will cross the placenta and have some effect on fetal thyroid. Therefore, it is important to use the lowest dose necessary, maintain maternal free T4 at upper limit of normal range. Both propylthiouracil and carbimazole can cause neutropenia, agranulocytes. Women must be advised to report symptoms such as sore throat or fever immediately, then urgent full blood count should be done. So next, there are pros and cons to both propylthiouracil and carbimazole. Propionthiouracil is traditionally favored up to at least 16 weeks of pregnancy. This is, I have mentioned, and often continued throughout the pregnancy. They can be continued, propionthiouracil, or this is due to increased risk of more serious congenital anomaly with the carbimazole use, particularly in the first trimester. Therefore, usually women who conceive while taking carbimazole will be switched to propionthiouracil as early as possible. But as we have mentioned, if you give the patient propionthiouracil, we have to monitor the liver function test after 3 to 4 weeks. And treatment, however, the most important principle is good control of hyperthyroidism. This is another opinion. One was we will give the propionthiouracil first 16 week, and then we can shift to carbimazole, or we can keep propionthiouracil throughout the pregnancy. But another is, however, the most important principle is good control of hyperthyroidism. Pregnancies where there is a poor control are more likely to result in complication than those well controlled on either drug. Decision to start, stop, or change antithyroid medication should therefore be made in consultation with the patient by an experienced obstetrician endocrinologist. Many women will be able to reduce or stop their antithyroid medication during pregnancy. Disease activity tends to fall in the second and third trimester. This is the rule for all autoimmune disease. Whenever patient comes with autoimmune disease, we say that disease will become better in the second trimester, second and third trimester, and there will be flare of the disease in the puerperium. So this is the same with the hyperthyroidism, Graves' disease. The disease activity tends to fall in the second and third trimester, but this must be done according to thyroid function test results and under the supervision of an experienced clinician. So how we will assess the patient with suspected or confirmed hyperthyroidism? We will check for past medical history, family history, current symptoms, palpitations. We will ask the patient about all these things: heat intolerance, weight loss, diarrhea, vomiting. We will, on examination, we can see maternal tachycardia, tremors in hands, eye signs, examphelos, and the goiter and brisk reflexes. Okay, then preconception care, aim for good control on lower dose of antithyroid medication, which keeps T4 in the upper end of normal range. We will make the patient euthyroid in the preconception care when it's euthyroid. Then we will ask the patient to stop contraception. Effect of uncontrolled disease, we will discuss these effects on with the patient, that uncontrolled disease on the pregnancy and baby, and Graves' disease can become better in the second and third trimester like all other autoimmune conditions. Importance on compliance to treatment, folic acid 400 microgram. These are the points in the preconception clinic. Then antenatal clinic, when patient become pregnant, she will be seen by MDT, and TFTs should be taken at booking. So when patient comes in the preconception clinic, we will we'll write back to the GP, and we will make sure, we will especially write it when that whenever patient becomes pregnant, and immediately request a thyroid function test. So thyroid function test should be taken at booking and at least 6 weekly thereafter. Antithyroid medication should be titrated to keep free T4 at the upper end of the non-pregnant range. Thyroid, and then we will, one thing is thyroid function test, and thyroid we will do at the pregnancy, and when we have a test, pregnancy test positive, then booking, and then we will repeat it 6 weekly thereafter. Whenever we change the medication, antithyroid medication, so we will repeat this to see the effect of that antithyroid medication. We will repeat the thyroid function test after 4 to 6 weeks. So, and also, as I have mentioned, the thyroid stimulating antibodies, these cross the placenta and can therefore have an effect on the fetal thyroid, potentially causing fetal thyrotoxicosis. This typically occurs at or after 20 weeks of gestation. So at the risk of fetal thyrotoxicosis is directly proportional to the antibody titer. So we will, at the 20 weeks, we will again check for thyroid stimulating antibodies, and we want to see the antibody titer, because if it's raised, the more chances, the more antibodies are crossing placenta and causing fetal thyrotoxicosis. And thyroid stimulating antibodies titer should be checked at booking 28 weeks in all women with current and history of hyperthyroidism. So this is very important point. This should be understood here. In the hypothyroidism, when we will discuss the hypothyroidism, because hyperthyroidism is dangerous for mother more, and then it's also dangerous for baby. Like, but Hypothyroidism is only dangerous for baby, not for mother. Whenever patient is the case of hyperthyroidism, so there can be 95% is a Graves' disease, which is autoimmune disease, which has thyroid receptor antibodies. So what happens if it's not treatable with antithyroid medication and we need to do the thyroidectomy? So patient has been undergone thyroidectomy, and now there is no source of thyroid. She is taking thyroxine. So basically, when hypothyroidism patient come, we will ask the patient what is the cause of hypothyroidism. Maybe cause of hypothyroidism is any autoimmune disease of the thyroid, which is slowing down the thyroid function, or maybe it is because of basically patient is having hyperthyroidism. She is having antibodies, thyroid receptor antibodies, but we treated the hyperthyroidism by removing the thyroid, and now we are giving thyroxine. So in those cases of hypothyroidism, when we will discuss the management, we will also look for antibodies, thyroid receptor stimulating antibodies, which are present in the Graves' disease. So thyroid stimulating antibodies will be checked in all patients whose name has ever been associated with Graves' disease. So we will check at booking and 28 week. If at booking it's negative, then at 28 week. But if at booking it's positive, then we will repeat at 18 to 22 weeks, because we want to check the antibody titer to see the assess the estimate. We want to estimate that how much it can affect to the baby. For all women with a positive thyroid stimulating immunoglobulin, monitor fetus for growth and goiter by serial ultrasound. Arrange for weekly check of fetal heart rate due to risk of tachycardia and can be done by community midwife. So these ultrasound, which are serial ultrasound, and also see goiter and IUGR, also tachycardia, oligohydramnios. These can be done by fetal medicine units. So antenatal care features on ultrasound should raise the suspicion of fetal thyrotoxicosis. But when we say we will do the serial ultrasound, what we want to see? We want to see the IUGR, fetal tachycardia more than 170, fetal goiter, accelerated bone maturation, signs of congestive cardiac failure, and the high drops. So if presence of any of these features requires urgent MDT assessment and planning, including input from an obstetrician, endocrinologist, fetal medicine consultant, neonatologist, and anesthetist. Regarding beta blocker use, if patient is having patient herself is having tachycardia in pregnancy, for control of symptom, we can give the beta blocker. Propranolol are used for symptom control such as tachycardia, palpitations, or tremors. Long-term use can lead to fetal growth restriction, and this should be monitored with serial ultrasound. However, where significant symptom exists, benefit of beta blockade usually outweighs this risk. If nothing works in the benefit of the patient, and we are unable to control the thyroid function test by antithyroid medication, and we see this she's deteriorating in pregnancy, we think that there is thyroidectomy should be done. So subtotal thyroidectomy can be carried out in pregnancy, and if required, is best done in the second trimester. It may be indicated in any of the following situation: inability to achieve euthyroidism despite high doses of antithyroid drugs, inability to tolerate oral medication, and non-compliance with treatment. Radioactive iodine therapy for hyperthyroidism is absolutely contraindicated in pregnancy and lactation. For those who have been titrated with radioactive iodine, conception should be delayed for minimum of 6 months until euthyroid. So this is the question they can ask in the part 1, part 2, that if the patient has taken radioactive iodine, for how long she should not conceive. This is the whole pregnancy that we did normal folic acid. We check the thyroid function test, and when pregnancy positive, at booking, and we will check at each trimester, and we will again test thyroid function test whenever we adjust the dose of antithyroid medication. And if she is taking uracil, she will be her liver function test will be checked after 3 to 4 weeks, and we will tell the patient if she is having sore throat or fever, she should come to hospital immediately, and full blood count will be done at that time. And we will have routine follow-up as well, that like down screening and also the mid-pregnancy scan. And after 20 weeks, we will again do the basically on booking, we did the thyroid stimulating immunoglobulin. And if it's positive, we will repeat at 20 weeks. And if it's negative, then we will do at 28 weeks to check again. So if it is positive at 20 weeks, we will do the serial ultrasound. So serial ultrasound will be done to see the goiter, hyperthyroid, tachycardia of the baby, IUGR, oligohydramnios, and these ultrasound will be done by fetal medicine. And if there is any risk, then MDT will decide what to do. And we will monitor the patient throughout the, if we are doing propranolol, it's again risk of the IUGR. So now patient has come to term. Now, intrapartum care, no alteration to normal care if hyperthyroidism is well controlled. In poorly controlled hyperthyroidism, there is a risk of thyroid storm or crisis, which is a medical emergency. That's why hyperthyroid patients they should be delivered in the hospital setting. They will not be delivered in the home birth, or they will not be given option of home birth or alongside or stand along midwifery units. What is thyroid storm? Why we want to deliver in the hospital setting? Because of fear of thyroid storm. It is also referred as as thyrotoxic crisis. This is rare, sudden, and life-threatening condition in pregnancy. It could be seen in undiagnosed or poorly controlled hyperthyroidism. This sudden flare-up of symptoms can be precipitated by labor, infection, or surgery. Symptoms and signs include fever, tachycardia out of proportion to the fever, hypertension, high output cardiac failure, restlessness, coma, seizures, gastrointestinal symptoms, pain, diarrhea, vomiting, and jaundice. So, thyroid storm is a medical emergency and is associated with high mortality. Rapid diagnosis and aggressive treatment are key. So, principle of management, thyroid function test should be taken prior to treatment, admission to a high dependency unit, and multiple disciplinary MDT care, including review by endocrinology, registrar, or consultant. And treatment is with high dose of propionthiouracil or carbimazole and potassium iodide or sodium iodide to suppress T3 and T4 production. High dose IV dexamethasone to block peripheral conversion of T4 to T3. Propranolol to control tachycardia, used with caution if any suspicion of heart failure. Phenobarbital to increase metabolic elimination of T4. Supportive therapy with IV fluid, oxygen, antipyretic should be administered. Avoid delivery during thyroid storm where possible and stabilize patient first. Then come the postnatal care. So patient should be advised to continue their current medication and have thyroid function test checked via GP at 6 weeks postnatally. If antithyroid medications have been reduced or stopped in pregnancy, most women, because we know that it will become better, autoimmune disease become better in the second and third trimester, and these will flare again in the puerperium. Because in the exam, one time they have given inflammatory bowel disease. So before that exam, inflammatory bowel disease did not come in exam. So it was very confusing for the candidates. But when they know that this is autoimmune disease, so then they can at least tell that it will improve in second and third trimester, it will flare in the puerperium. So if antithyroid medication have been reduced or stopped in pregnancy, most women will need to restart or increase these in order to avoid a relapse. Neonatal care is very important because neonatal team need to be informed of delivery and should examine the baby. Baby should be observed on the ward for 48 hours and will need a blood test for thyroid function test at age 5 to 10 days. For the hyperthyroidism, certain conditions are checked when the baby is born by heel prick test, where they check for thyroid function test, sickle cell disease, cystic fibrosis. So baby will be checked for thyroid function as well. So breastfeeding, low concentration of propionthiouracil is found in breast milk. Significant higher concentration of carbimazole in breast milk. Although this does not show any adverse effect in infant, data is limited. So patient on any drug can feed the baby. Thank you so much. This is all about hyperthyroidism in pregnancy.